Hello and welcome everyone. So I would like to welcome you again in NEET PG exam preparation. This is a platform of Unacademy platform. So I'd like to welcome you in this Unacademy platform where we'll be doing about let's crack NEET PG. So okay. So now myself, I am Dr. Anil Sharma. Basically, I am Dr. Anil Sharma, and I am a MD pathologist from AIIMS. So we have been we have been together for more than 2 months now, and this before going ahead, what you need to know is you need to be part of our family. And how can you be part of our family? But you can just write down Unacademy Learning app in your Google Map and just install this Unacademy Learning app. So after installing this Unacademy Learning app, you can subscribe. You can get plus subscription or iconic subscription. Okay. So basically, plus subscription is all about live classes, live test and quiz, batch courses, structure schedules. So you can get live classes like the present live class. And in iconic you can get one very good gift, that is you can get prep ladder also. So the videos of prep ladder, the question bank of prep ladder, the past year questions of different exams like AIIMS, PGI, rapid revision courses, and handwritten notes, all you can get in iconic subscription. So now the price part of the subscription, basically if you are getting doing iconic subscription, it can be taken off 12 months, 18, 24 and 36. For 12 months it costs you around 55,000 rupees, which if you use the promo code ANLIVE, you can get it into 49,500 rupees for 12 months. Okay, so this is my promo code you can use, and you are getting a discount of around 5,500 rupees. And for the plus iconic, you can subscribe for 1 month, 3 months, 6 months, 12 months, 18 months, 24 months and 36 months. You can use my promo code ANLIV to get 10% discount in each segment. Okay, so in each segment, like if you subscribe for 12 months, you will be paying 24,750 instead of 27,500 rupees. Okay, so you can use the promo code ANLIV Anil Live. So this will give you 10% discount. So the best reason for Unacademy, what I feel, is basically the team. So the mentors. So basically you have very good mentors, and this like Janab Bora of MD in MD Radiology. She is from AIIMS itself, and she is a wonderful teacher. Dr. Pawan Kandhari, Dr. G Rajesh. So G Rajesh basically he is doing it. He will be teaching you general medicine, and obviously all the concept of general medicine will be cleared by him. So he's a wonderful teacher. Similarly, Dr. Preeti Sharma, she has a knowledge, ocean of knowledge for pathology. She's a gold medalist in pathology, and she's in the basically you can just be sure that if you get her teaching, pathology will be made so simplified, and basically it's a cake of walk. Okay, so just it's like eating cake, nothing more than pathology. Will be very very easy. So you get these mentors, and these mentors are basically helpful, will be helping you how to crack NEET PG along with me. So let's crack it. Okay, let's crack it. So now today what we are going to do is basically we'll do about the plasma cell disorders. Now when I say about plasma cell disorders, so firstly we'll talk about some of the basic concept of plasma cell disorders. Okay, so everyone says plasma cell disorders is difficult, it is. So basically first let's understand the basics. Okay, basics जानना जरूरी है. So we need to know about the basics of plasma cell disorders. And what is basic of plasma cell disorders? Have you watched TENET? So before watching TENET, what you need to know is you need to know about theory of inversion. Okay, before watching TENET, what you need to know? You need to know about the theory of inversion. Okay, time inversion, theory of time inversion. Again, you should also know about the concept of entropy. Okay, you should know about the concept of entropy. So similarly, before we start the plasma cell disorder, we should know about the basic things what we are going to use when we will be studying plasma cell disorder. So one is plasmablast. So basically the plasmablasts are the precursor to the plasma cells, which produces more antibodies than B cells. Okay, but less than the mature plasma cells. Okay, So they are the plasmablasts are the precursors of the plasma cells. So plasmablasts, then plasma cells are formed. So the plasma cells are the last stage of B cells. So from where these plasma cells are coming? The plasma cells are developing from the B cells. Okay, so B cells. So basically pre-germinal, germinal center, and post-germinal. So plasma cells are basically post-germinal B cells. Okay, so these plasma cells, they basically express CD38. Okay, CD38, bright CD38, but they lose CD19. See, B cells, so when we say about B cells are 1920 positive. Okay, B cells are CD19, CD20 positive, but plasma cells, they will lose this CD19. They will start losing CD19, but they will express CD38. So this is basically characteristics which you get in plasma cell. Okay, this will be the characteristics which you get in plasma cells, and very important questions forms with this concept. I'll just form some questions and live in front of you and show you. Plasma cells cannot act as antigen presenting cells. So plasma cells are the antigen presenting cell? No, because they do not express MHC2, and they cannot switch antibodies classes. Okay, so plasma cells, they are not responsible for switching antibody classes. Okay, so they will only produce one kind of antibody, either IgM, either IgG, IgE, IgD, like that. Okay, so these are the basic concept. Okay, so plasma cells, they are forming from B cells. Okay, so B cells, B cell maturation. So this plasma cell later on will form immunoglobulins. Plasma cell later on will form immunoglobulins. Plasma cells are CD38 positive, and they lose CD19 which is B cell markers. Okay, very important point, इसको ध्यान रखना. This is basic concept. When we will do immunophenotyping, we will be using this basic concept again. ठीक है. Now then again, when we show in your exam, you can be asked which cells are these. Okay, so this basically they can say you lymphocyte. Okay, they can say you monocyte, they can say you lymphoplasmacytic cells, okay, or they can say you neutrophil, they can say you plasma cells. Okay, so the right answer will be plasma cells. So these are the plasma cells. So this can be a theoretical question. So these are the plasma cells. So now what are plasma cells? Peripheral blood means anywhere. So see, image is image. Now you will see such type of cells everywhere. If you see in basically in your biopsy, okay, biopsy, or in your aspiration, bone marrow aspiration, anywhere you see these things, plasma cell will be like this only. So basically this is the nucleus. I'll just restart again. So here see, this is basically your cytoplasm. Okay, this is your cytoplasm. Okay, so this is your nucleus. Okay, so this inside nucleus you are seeing, so this all are this dark part. So this dark part, basically this is chromatin. Okay, so this is about the plasma cell. So now here see, this nucleus, and here around the nucleus you can see here this is a space. So this space is known as perinuclear half. So perinuclear half. Now this perinuclear half is basically nothing, it's because of Golgi bodies. This is because of Golgi bodies. Okay, this is cytoplasm, this is cytoplasm. Okay, now when you describe plasma cell, what are plasma cells? Are cells which have nucleus is located peripherally. So nucleus is located peripherally, having a perinuclear half with chromatin giving clock face. So see, this are like clock, no? There's black, then there's whitish region, black. So chromatin, this is clock phase, or this also can be your cartwheel type of. So this also gives you gives like cartwheel type. Okay, so CART, cartwheel type. Okay, or clock face. So characteristic feature, chromatin, coarse chromatin, and clock face pattern. So the chromatin is in clock face pattern. They can be binucleated cells occasionally, but there is basically nuclei is not present. But in plasmacytic cells, lymphoplasmacytic cells, plasmacytoid cells, another cells that can be plasmacytoid. So another cells is plasmacytoid. So in plasmacytoid cells, what happens? There will be nucleoli will be present. What? Nucleoli will be present. Okay, so these are plasma cells. Remember, these are the plasma cells, and basically there can be vacuolation and all. So this is vacuolation in cytoplasm. So this is basic structure of a plasma cell. Now another thing you need to know, basically basic thing is Russell bodies. So when you are talking about multiple myeloma or any plasma cell disorder, you should know about Russell bodies. So Russell bodies, they are nothing but they are the globules of accumulated immunoglobulin. See, they are the accumulated immunoglobulin. What are Russell bodies? Nothing, they are the accumulated immunoglobulins in the cytoplasm of the plasma cells. Okay, Russell body is seen in cytoplasm. Okay, so Russell body basically is seen in Russell U. So this U, you can take it C. So okay, inverted C. So Russell body is in cytoplasm. Okay, so Russell body is in cytoplasm, or S, when you write S, basically this is more important. Russell body is in cytoplasm. Okay, now there are multiple round cytoplasmic hyaline inclusion. Okay, so there basically when you see in biopsy, you will see hyaline inclusions. Okay, hyaline inclusions which you can see in bone marrow aspiration and myeloma, and they are basically accumulation of immunoglobulins. Okay, see, these are the Russell bodies. See, so this is the nucleus, and here in the cytoplasm, all these vacuolated things you are seeing, so they are the Russell bodies. So they are the Russell bodies. Okay, so they are the Russell body. Here they are the Russell bodies. So this is classical Russell bodies you can see in cytoplasm. Russell bodies are seen in cytoplasm. So now another concept, Mott cells. So what are Mott cells? So Mott cells are basically the plasma cells which is crowded with the Russell bodies. So this is plasma cells. So here you have a lot of Russell bodies. So when cytoplasm has lot of Russell body, then that is called as Mott cells. What is that is called? That is called as Mott cells. So this is Mott cells. Okay, so this is basically Mott cells. And obstruction blocks the release of Golgi secretions, and this is because an obstruction, it is the Golgi, they can't secrete, and hence when they can't secrete this, there will be space will be formed. So this cell can be, now they are not specific for plasma cell, they can be found in any chronic plasmacytosis. Okay, so not for multiple myeloma, specific nahi hai, but you see. Another important is Dutchess body. Okay, so now Dutchess body is basically nuclear, intranuclear inclusions. So remember, so it's not C, that is C in Dutchess, but actually it's not cytoplasmic, it is nuclear, intranuclear inclusion. Okay, Russell's body is basically intracytoplasmic. This is intracytoplasmic, we call it cytoplasmic, and Dutchess body is intranuclear. Dutchess body is intranuclear. Okay, see here, so this is nucleus, so here something nuclear inclusion. Okay, so this is also nuclear inclusion. So this is basically your Dutchess body. So this is your Dutchess body. Dutchess body, which you see, basically it is intranuclear inclusion found in plasma cells. Okay, so now here, see, this is your Dutchess body. So Dutchess body, and this is your basically nucleoli. This is your nucleoli. So basically Dutchess body is basically this Dutchess body, it will be shining. Okay, and nucleoli will not shine like that. So here this is the difference in intranuclear inclusions and nucleoli. Okay, now basically as I said inclusions, as I said Dutchess body, I talked about your Dutchess body, I talked about your Russell's bodies. There can be other, and Mott cells, there can be others inclusions also in plasma cells. So plasma cells can have different inclusions like Snapper-Schneid's granules. So now you might not have heard about this. So this is Snapper-Schneid granules, you can get this. You can also get crystals that resembles Orr's rod. You can get Dutchess body, you can get Russell's body, and you can get Mott cells. Okay, so basically this Snapper-Schneid granules are nothing but they are the Prinkies granules. Okay, so these granules later on they can form rod also. So this is basically a classical example of Snapper-Schneid's granules. So you can be asked in exam which of the following is plasma cell inclusion, which of the following is plasma cell inclusion, and you can be given this as A, B, C, D, and your answer will be all right. Okay, so that you need to know. You have not heard this, so you might tick this as a wrong option. So obviously this is only the question which can be asked regarding snapper, sned, and granules. So remember, this is also a variant of plasma cell. That is important takeaway from here. Okay, now next thing. So now another important cell which you need to know about is basic cells you need to know about is phlegm cells. Okay, phlegm, by the name itself only, obviously there will be some flaming things. Okay, so this is basically phlegm cells is atypical plasma cell with irregular cytoplasmic projection. Like hairy cell leukemia, hairy cells, they will have irregular cytoplasmic projection, and this cytoplasmic projection will stain purple red with Wright's Giemsa stain. Okay, so now why these cells stain purple red? Because this is mostly seen in IgA myeloma. Okay, because IgA, so this immunoglobulin A myeloma, so the plasma cells which are form of IgA, plasma cell form of IgA, basically they have the external covering, they have more carbohydrates. Okay, so because of this excess carbohydrate, they will stain purple. Okay, so this is usually with IgA myeloma, but can also be seen in non-IgA myelinomas and monoclonal gammopathy of undetermined significance, as well as in reactive plasmacytosis. So this is also not characteristics for plasma multiple myeloma. So these are the phlegm cells. See, like phlegm, fire ka phlegm. So these are the phlegm cells. This is plasmacytoid cells. There is a nuclear Hoff, and these are the phlegm cells. Okay, so they are nuclear Hoff, and this is characteristic staining is thought to be related to high carbohydrate content of IgA molecule. Okay, so now basically IgA content is highest in carbohydrate content is highest in IgA. That now you need to know. So these are again Russell bodies. So these are the hyaline like dropslets here. These all are Russell bodies. Okay, these are the Dutcher's body. So these are the Dutcher's body. Dutchers are nuclear, and Russell bodies are cytoplasmic. So but now the take home message over here is none of these interesting inclusions they are specific for malignancy, nor they have prognostic value. So they, if you find them, they don't have any significant, neither they are diagnostic because they can be found in another chronic plasmacytic reactions also. So you never say that if Russell's body is present, it is multiple myeloma, or Dutchess body is present, it is multiple myeloma. No, in multiple myeloma, there are chances that you will find Russell bodies and Dutchess bodies. But if you find Russell's body and Dutchess body, then don't say that that is multiple myeloma. Okay, you need to. So now, before going further, I'd like take this chance to explain you about the peripheral blood smears finding. So what is this? So this is basically a monocyte. So when we define cells of peripheral smear, then we say that is granulocytic. Okay, there will be granulocytic and agranulocytic. Okay, agranulocytic. So basically granulocytic means those which have granules, basically azurophilic granules plus specific granules. Okay, okay. Then agranulocytics, they can have azurophilic granules they can have. Okay, this is can be plus minus, but they don't have specific granules. Okay, these are absent, specific granules are absent, so this is important. Okay, then remember granulocytics are, so granulocytic are your neutrophil, okay, neutrophil, basically basophil and eosinophil. Okay, and agranulocytics are basically your monocyte and lymphocyte. Okay, so this you need to know. Now this, what is this? This is a neutrophil, this is a lymphocyte, and this is a monocyte. Okay, then again this is a lymphocyte, this is a small lymphocyte, medium sized lymphocyte, and large lymphocyte. So now again this feature, what is this feature showing? This is showing a neutrophil and eosinophil with basically this, they are the granular basically orangophilic granules. Okay, and this is a basophil. So this is a basophil. Okay, this is an eosinophil, and this is a neutrophil. Okay, this is important. Now this is a bone marrow aspiration showing a lot of plasma cells. So see, this is a plasma cell, this is a plasma cell. So there are a lot of plasma cells in this bone marrow biopsy. So now, what are the conditions which have circulating plasma cells or differentials of plasma cells? So there can be malignancies like multiple myeloma, plasma cell leukemia, gamma heavy chain diseases, and chronic lymphocytic leukemia. Other neoplastic states like in breast carcinoma, in prostatic carcinoma, you can see circulating plasma cells. In viral infections, rubella, varicella, and infectious mononucleosis. In bacterial infections like streptococcal, syphilis, and tuberculosis. Parasitic infection, malaria, trichinosis, allergic states like drugs and antitoxins, and miscellaneous like pockweed mitogens, transfusions, hyperimmunization, trauma including fractures, and chemotherapy. So these are some of the conditions which you can see plasma cells. Okay, so you can be asked which of the following do not contain plasma cell. Okay, so which of the following do not contain plasma cells? 1, multiple myeloma. Okay, number 2, rubella. Okay, number 3, malaria. Number 4, LPL, lymphoplasmacytic lymphoma. Okay, so the answer here will be LPL. So here they are not plasma cells, they are lymphoplasmacytic cells. Okay, not plasma cell. All other conditions will have plasma cells, but in LPL there will be lymphoplasmacytic cells. Okay, so lymphoplasmacytic, they will be plasmacytoid cells but not plasma cells. They are not plasma cells. Okay, that is important. Table 2. So the conditions which will have plasmacytoid lymphocytes, okay, like Waldenstrom macroglobulinemia, gamma heavy chain disease. So this Waldenstrom macroglobulinemia, it will have plasmacytoid lymphocytes. Viral infection like infectious mononucleosis, infectious hepatitis, viral gastroenteritis, and upper respiratory tract infections. In allergic states like p-aminosalicylic acids, diphenylhydroetoin sodium, and miscellaneous pemphigus, ulcerative colitis, idiopathic agranulocytosis, post-cardiotomy, and chemotherapy. So these are the conditions where you will have plasmacytoid. So plasmacytoid cells are like plasma cells. The nucleus will be lying peripherally, but there will be no nuclear half, or there will be no cartwheel or clock face or cartwheel pattern of chromatin. So no nuclear half, or no cartwheel pattern or clockwise face of these plasma cells. Okay, so this again you need to remember. So here what kind of question can be asked, we have discussed about that. Now coming to the plasma cell dyscrasis. So what is plasma cell dyscrasis? It's a spectrum of disorders where there will be neoplastic proliferation of plasma cells, then there is where there is excess production of monoclonal proteins. Okay, so this is basically first thing you need to know is monoclonal proliferation. It is monoclonal proliferation. Okay, it is monoclonal proliferation. So before going again entering another basic concept you need to know is what is this M proteins. So this M proteins is basically, some of you think that M protein is like IgM. Okay, so no, M protein is not only IgM. Basically you see immunoglobulins, they are made, or antibodies are made up of one heavy chain and two identical light chain. Okay, you know very well this. Okay, so this is here two identical light chain. So this is what your immunoglobulin is made up of. Okay, so that will be one heavy chain and there will be two light chains. So now what you need to know here is basically heavy chain is alpha, delta, epsilon, gamma, and mu. Okay, so alpha, delta, epsilon, gamma, and mu. That is, alpha is A. Basically this is D, E, G, and M. Okay, so you also can remember this is gam D. Okay, gam D. D for delta, E for basically your epsilon. Okay, A for alpha, and G for gamma, okay, G for gamma, and M for your mu. So this you need to know. And there are two light chains, that is kappa light chains and lambda light chains, okay. So this is the basic thing of an immunoglobulin. So now I'll just take chance to explain you more about this. There are IgG, IgA, IgM, IgD and IgE. So now they can be, see, maximum percentage is of 75% of IgG, okay. The structure is mostly monovalent. IgA can be monovalent or divalent. IgM can be mono and penta. IgD is mono, IgE is mono. So IgG is gamma, IgA is alpha, IgM is mu, and delta and epsilon chain, okay. Complement fixation is done by G and M. And transplantation cross can happen only in case of IgG. Allergic response will be given by IgE. Secretions found in secretion will be in IgA. Opsonization will be done by IgG, and J segment is found, or joining J segment is found in IgA and IgM. So these are basic structures or basic thing you need to know about the immunoglobulins. So M proteins, basically they are the refers to the presence of homogeneous protein in the serum or urine, okay. So this homogeneous protein, that is like IgA, immunoglobulin G, D, E, M, okay. So they are detected by the electrophoresis and synthesized by monoclonal plasma cells. So maybe complete immunoglobulin molecule or same class, or can be light chains of same type, or maybe heavy chain of same class, okay. So M protein are basically, they can be immunoglobulin, okay, immunoglobulin, basically they can be light chain, okay, and they can be heavy chain. So this can be M proteins. Remember, they are not an immunoglobulins, any immunoglobulin, okay. Not only IgM, it can be any. It can be A, it can be G, it can be E, okay, any immunoglobulin. Then another basic thing which you need to know about when you talk about multiple myeloma is CRAB. That is, evidence of end organ damage will be shown by CRAB. CRAB is C for calcemia, that is hypercalcemia, R for renal insufficiency, A for anemia, and B for bone lesions. So C for hypercalcemia should be more than 11 milligram per deciliter, okay. So this should be at least greater than 1 milligram per deciliter, higher than the upper limit of the normal, that is greater than 11. In India it is greater than 10. All over the world it is greater than 11, okay. Renal insufficiency, the creatinine clearance should be less than 40, okay, or it should be greater than 2 milligram per deciliter, okay. Creatinine clearance less than 40 or greater than 2 milligram per deciliter creatinine, okay. Anemia, hemoglobin greater than 20 gram per deciliter, okay, that is 2 gram per deciliter, greater than 2 gram per deciliter than the lower limit or the higher limit, okay. That is basically hemoglobin level less than 10 gram per deciliter, okay. 10 gram per deciliter, this is equal to 10 gram per deciliter, okay. So bone lesion, there should be punched out bone lesion, that is osteolytic bone lesion on skeletal radiography, CT or PET scans, okay. There is, you can, skeletal radiography is done, CT scan or PET scan. So if bone marrow has less than 10% clonal plasma cells, more than one bone lesion is required to distinguish from solitary plasmacytoma with minimal marrow involvement, okay. So there should be more than one or more than one osteolytic lesion. So this is basically CRAB criteria, CRAB. So this CRAB criteria, basically this criteria is fulfilling, then you say it's an end organ damage. So that end organ damage is again important in case of multiple myeloma, okay. So when we talk about these cells, when we talk about plasma cell disorder, so we need to know about the end organ damage, okay. We need to know about the end organ damage, and basically end organ damage is explained by this 4 things. So these all are the basic things, okay. So we talked about, so basic things. So what all basic things we talk about? So we talked about different basic things, okay. We talked about basic things, and these basic things you need to know before starting plasma cell disorder, okay. Like before watching Tenet, so Tenet, पता है ना movie? किसको पता है, किस बहुतों ने देख भी लिया होगा. So tenet, when you watch TENET, tenet, so this movie basically you need to know about the time inversion theory, and you need to know about the basically entropy theory. Okay, entropy theory. So if you are well versed in these two theory, then you can watch tenet. So now hence before starting plasma cell disorders, you need to know about what you need to know about plasma cells. You need to know about plasmacytoid cells. Okay, you need to know about the Dutcher cells. Okay, you need to know about Russell cells. You need to know about Mott cells. Okay, so these are different types of cells you need to know about in case of when you start about plasma cell disorders. Okay, now when you know about these cells, now what you need to know, next thing you need to know about this classification. So WHO classification of plasma cells. So what all things are included in plasma cell neoplasm. So when I say plasma cell neoplasm, it's not only multiple myeloma. So plasma cell neoplasm is MGUS, that is MGUS. Remember, monoclonal gammopathy of undetermined significance. This is known as pre-malignant condition or precursor lesion. Okay, so this is called precursor lesion also. So the chances of this going into the plasma cell myeloma is around 1%. Okay, now so remember, monoclonal gammopathy of undetermined significance, it is non-IgM type. Okay, non-IgM type. So MGUS can be IgM and non-IgM. So it is in plasma cell neoplasm, it is non-IgM type is classified under this thing. Okay, so now here Swata, you will be getting a question, which of the following is plasma cell neoplasm? Okay, so which of the following is plasma cell neoplasm? So 1, non-secretory myeloma. 2, primary amyloidosis, except, so basically you should say except. Okay, all of the following are plasma cell neoplasm except primary amyloidosis. 3, non-IgM MGUS, or 4, IgM MGUS. Okay, so the option will be IgM MGUS. IgM MGUS is not a plasma cell neoplasm. Okay, IgM MGUS is not a plasma cell neoplasm. This you need to remember. Okay, so we'll come back to this thing theory again. You have plasma cell myeloma. So plasma cell myeloma basically smoldering plasma cell myeloma, non-secretory myeloma, and plasma cell leukemia. Plasmacytoma, there are solitary plasmacytoma born and extramedullary plasmacytoma. Then you have monoclonal immunoglobulin deposition disease like primary amyloidosis and systemic light and heavy chain deposition disease. Then you have plasma cell neoplasm with associated paranaplastic syndrome like POEM syndrome and Tempe syndrome. So Tempe syndrome is at present provisional entity. Okay, so again a question is formed, which of the following is provisional entity in plasma cell neoplasm? Which of the following is provisional entity in plasma cell neoplasm? Okay, so the answer will be Tempe syndrome. They can give you POEM syndrome, primary amyloidosis, systemic light and heavy chain deposition, and Tempe syndrome. So Tempe syndrome is basically a provisional entity in WHO classification of plasma cell neoplasm. ठीक है, so ये एक दूसरा MCQ बन गया. ठीक है, and here you have one MCQ. So this is important. So what the etiology of this? So basically etiology is basically unknown. So etiology is unknown, but yes, chronic antigenic stimulation from infection, chronic diseases, radiations, specific toxic substance. Cosmetologists are also under high risk of multiple myeloma. Farmers are chronic laxative abusers, and hereditary in non-IgM monoclonal gammopathy of undetermined. So in non-IgM MGUS, you can see hereditary also. Okay, hereditary also plays a significant role. So when I say about monoclonal gammopathy, so see, must say MAM is MGUS, that is monoclonal gammopathy of undetermined significance. This is pre-malignant. Okay, this is pre-malignant. So there are others also like lymphoproliferative disorders, amyloidosis, smoldering, plasmacytoma, okay, and others. So basically see, plasma smoldering multiple myeloma, plasmacytoma, and multiple myeloma, which is around second highest. Okay, so now this you need to remember. So they all are monoclonal gammopathy. So since this is monoclonal gammopathy, hence you are saying lymphoproliferative disorder also coming in this. Okay. So now what are the investigations? So you need to know investigations of this also. This is also basic things. See, I'm not going in disease process at present. I'm just showing you overview. Okay. So basically investigations, when you are suspecting monoclonal gammopathy, then the investigations which all you should do is complete blood count. So complete blood count, you look for anemia. There are chances that can be anemia. Look RBC figures. So we'll talk about what you will see in RBC. Then you can do comprehensive metabolic panel. So you can do serum creatinine, serum, obviously you can do serum sodium, potassium and all. So all complete metabolic panel need to be done. So look for renal insufficiency like hypercalcemia, subtle clues like decrease in iron gaps and all. So they will help in kidney disease, diagnosing kidney disease and organ damage. Okay, then you can investigate or you can measure the immunoglobulins. Okay, so you can measure quantitative immunoglobulins. Okay, then you can do serum protein electrophoresis with immunofixation. You can do 24-hour urine protein electrophoresis with urine immunofixations. Okay, so this is the quantitative. Basically you do by nephrometry. Okay, you do by nephrometry. So this is important, you do by nephrometry. So basically then you can do serum electrophoresis, protein electrophoresis, this is electrophoresis, and again immunofixation. You can do 24-hour urine electrophoresis with urine immunofixation. So here what you do, you see for serum free light chain assay, kappa and lambda ratio may also be used in place of UPEP. You do bone marrow biopsies and aspirations to evaluate percentage of plasma cells, because percentage of plasma cell is also one of the diagnostic criteria for plasma cell disorders. You can do skeletal survey if monoclonal gammopathy have been established, and then you can do beta-2 microglobin and albumin. So this beta-2 microglobin and albumin is basically for staging process and prognosis in multiple myeloma. Okay, once diagnosis is made, so for the staging process and the prognosis, you do beta-2 microglobinemia. Okay, stage 1, stage 2, stage 3 is explained about according to the amount of albumin and beta microglobulin. So we'll do, when we do stage of multiple myeloma, we'll see role of this. But yeah, beta-2 microglobulin have role in basically prognosis of multiple myeloma and staging. So this becomes again another question. Okay, so beta-2 microglobulin have role in diagnosis, prognosis, staging, okay, or no role. So basically it is in prognosis and staging. So what are the ideal, so these all are the screening patterns. So ideal screening panel for monoclonal gammopathy is serum electrophoresis, serum protein electrophoresis. You can also do serum protein electrophoresis with serum immunofixation. You can do this both by free light chain assay, okay, serum free light chain assay, or you can do serum protein electrophoresis and serum free light chain, or you can do comprehensive, that is serum protein electrophoresis, serum immunofluorescence, free light chains, and UPEP, okay, urine protein electrophoresis. So serum protein electrophoresis, so here what happens, you have serum, it is placed in a special paper which is treated with agarose gel and it is exposed to an electric current. Okay, so for what all it is dependent, it is dependent on size, electrical charge, the current, the medium on which you put. Okay, so all this affects the movement of the proteins. Okay, so basically then you can see different proteins like albumin and globulin. So you can see there are these are the globulins and these are the albumin. So there will be two things, that is albumin and globulin. Okay, so albumin and globulins are two different types of proteins found in the serum electrophoresis. So again, globulins can be alpha 1 globulin, alpha 2 globulin, beta globulin, and gamma globulin. We'll talk about this very soon. And immunoglobulin like IgG, IgM, IgA they usually migrate to gamma region, okay, but they can also migrate to beta region. So serum protein electrophoresis should always be performed in combination with serum immunofixation. We'll talk about this in order to determine chronicity. So what is this? Is that serum electrophoresis will say you whether any type of protein is present in excess amount or not. Okay, it will say whether it is present in polyclonal way or monoclonal way. Okay, there is polyclonal proliferation or monoclonal proliferation. You can know about serum electrophoresis. Serum immunofixation, you can know that which type of M protein or which type of antibody is proliferating. Okay, which type of antibody is in excess, that you can know by serum immunofixation. Okay, so there are two groups, as I said, albumin and globulin, and these two groups can be separated into 5 small groups. Okay, so this is 5 small groups. One is albumin, so more than half of the protein in the blood serum. Okay, albumin is greater than 50%, greater or equal to 15%, and what this, it keep the blood from leaking out. It does not let the blood to leak out of the blood vessels, and also it also carry some medicine through as a carrier. Okay, through as a carrier. You have then globulins, that is alpha 1 globulin. So alpha 1 globulin, like alpha 1 antitrypsin, alpha 1 chymotrypsin, alpha lipoprotein, so they all comes under alpha 1 globulins. Basically one of the best example is SDL, high density lipoproteins. Okay, that is good type of cholesterol is included in alpha 1 globulin. Okay, so basically your examiner will test from here which of the following. So like SDL is alpha 1 globulin, alpha 2 globulin, gamma globulin, or albumin. So basically it is alpha 1 globulin. Alpha 2 globulin basically is alpha 2 macroglobulin and haptoglobulin, major one. Okay, then beta globulin, you have beta globulin, that is beta lipoprotein complements C3. So this is beta globulin, beta lipoprotein and complement. So they help in carry substances such as iron through bloodstream and help fight infection. Then you have gamma globulin. So this gamma globulin, what it does, it helps in prevent fight and infection. Then obviously they all are the polyclonal antibody which comprise of heavy chain, okay, GAMDE, and light chain, kappa and light chain. So these are the gamma globulins. Okay, so these are different types of globulins and albumin proteins which separates by electrophoresis. So see, this is an albumin, and then you can alpha 2, beta 1, beta 2, and gamma. So this is according to size and charge. Okay, and whenever there is a dark band seen in globulin region, gamma region, dark band region seen, that is called monoclonal component. Okay, monoclonal component. So this is basically serum electrophoresis. This is normal serum serum protein electrophoresis. So basically this is albumin, this is alpha 1, alpha 2, beta 1, beta 2, and gamma. Okay, see, and this again here you can see M spike, that is gamma globulin. So spike in the gamma globulin region and the band, dark band. So this proves that there is monoclonal proliferation of immunoglobulin. Okay, so there can be also polyclonal gammopathy. So in polyclonal gammopathy, so this is albumin, this is alpha 1, alpha 2, beta, and this is gamma. So this gamma have increased, but it has not undergone dark, but yeah, its diameter is increased. So this proves that it is polyclonal. Okay, so basically it's proved it is a polyclonal, and the peak is, so it is not, peak is not like this. Okay, tip like, okay, it's a broad base. Okay, base is broad, so broad base. Okay, base is broad in case of polyclonal. If in case of polyclonal gammopathy, okay, polyclonal gammopathy. So this can be seen in chronic infection, inflammation, connective tissue disease, and lymphoproliferative disease. Okay, so in exam you can be asked, what does A, B, C, D show? Okay, so what all this show? So basically A is your normal case. Okay, B is your basically polyclonal, and C is your multiple myeloma, band is formed. Okay, and D is your hypoalbuminemia. Okay, albumin have been so light, so this is basically hypoalbuminemia, maybe in nephrotic syndrome. Okay, so your A is normal, Okay, B is your polyclonal, C is your multiple myeloma, monoclonal, and D is your hypoalbuminemia. ठीक है? So you can see here again this is saying this is gamma region, very dark brand. So this basically is M proteins, that is monoclonal gammopathy with large M protein. Okay, this is very light, so basically it's a monoclonal gammopathy with a quantitatively small M protein. This is increasing, just very light and increasing, so this basically shows polyclonal hypergammaglobulinemia. Here this gamma region is completely lost, this is hypogammaglobulinemia region, okay, with low serum albumin, that is nephrotic syndrome, see in this region. And here basically again you can see hypogammaglobulinemia, serum albumin is here is dark, so it is normal serum albumin, this is low serum albumin. Okay, so this you need to know about this electrophoresis, SPE. So you can be given this drawing and you can be asked, so A, B, C, D. So what does A, B, C, D refers? Okay, so this is another question. Now immunofixation, this is more sensitive and obviously it tells about the type of immunoglobulin. Okay, whether it's IgM, whether it's IgD, whether it's IgE, so which type of immunoglobulin. So it is immunofixation will tell about that. Okay, so suppose this is your A, so here you can see the normal feature. Okay, then sorry, the gamma, so this is gamma component is seen, sorry not normal, this is gamma component is seen. So in this gamma component, what is increased, see in case of this, so in when you see this, so there is IgG is increased and obviously lambda is increased, so IgG lambda. Okay, so which type? It is IgG lambda, so G lambda type of monoclonal antibody is increasing. So here again you can see lambda type, all other are not seen, but this lambda type is increasing. Okay, so this is lambda is increasing, light chain lambda. So this is basically light chain and light chain monoclonal MGUS. Okay, so this is basically light chain MGUS. So we have talked about electrophoresis, we have talked about immunofixation. So next investigation which you can do is serum free light chain assay. Okay, so the serum free light chain assay is that this is an intact immunoglobulin. Okay, so the intact immunoglobulin will have one exposed surface, another is hidden surface. So now this your hidden surface, if it becomes exposed one, that is light chains. Okay, so previously it was hidden surface, now it becomes exposed one, this is free light chain. Okay, so plasma cells are those who secretes complete immunoglobulins and obviously the light chains, they secrete the light chains. So the kappa light chains which are basically monovalent and lambda light chains can be divalent. Okay, lambda light chains can be divalent and kappa light chains are monovalent. So now physiology of light chains, so basically in a day around 500 milligram per day light chains are made. About that, less than 1 gram per day are filtered through the glomerulus filtration rate. Among that, 10 to 30 gram per day is reabsorbed at proximal tubules. Okay, then there can be deposition of light chain in case of DCT, descending curve, ascending curve. Okay, ascending tubules, and in tubules you can collecting ducts, you can find 5 to 10 milligram per day in the urine. Okay, so tubules they can absorb 10 to 30 grams per day. Okay, tubules can absorb 10 to 30 grams per day. Okay, so lambda is dimeric and kappa is to lambda is 2:1. This is normal ratio, and lambda also has a longer half-life. Lambda has a longer half-life. Remember, T half-life varies from 1 to 2 days. Okay, 1 to 2 days they vary. Okay, so these are the important basic points about light chain in tubules. Okay, so serum free light chain, it basically it eliminates need to collect urine specimen, and what it is more sensitive than both electrophoresis and immunofixation. And what are the indicators? So the most important thing is that serum free light chains are helpful in prognosis and risk stratifications. Okay, they help in diagnosis, but along with diagnosis they help in prognosis and risk stratification. They help in response assessment on therapy, and obviously help in disease monitoring on follow-up. So now this is important, they help in monitoring, they help in prognosis, risk stratification and response assessment. Okay, so this is your question which will come in an exam. Now these are the B cells. Okay, so these are the precursor cells, and these are the immature naive B cells, and these are the post germinal cells and germinal cells. Okay, so see, remember, so this is the formation how plasma cells form from the B cells. So B cells से plasma cells ऐसे form होता है, ठीक है. So the post germinal से the plasma cells. So the plasma cells are basically CD138 positive, CD79A positive, but CD19 it starts losing CD19. So IHC when we do, so basically see multiple myelomas, they are always CD19 negative, unlike normal plasma cells. Okay, that you need to know. So if it is a multiple myeloma cell, they will be CD19 negative and CD56 positive in case of multiple myeloma. They are CD6 positive. Okay, that you need to know very well. There can be cyclin D1 positive cases also because of translocation 11-14 like of mantle cell. 11-14 किस में दिखता है? Mantle cell, in mantle cell lymphoma. So like that 11-14 translocation is also seen in multiple myeloma. We'll talk about that. So basically multiple myeloma are CD56 positive, CD19 negative. Plasma cells are CD19 positive, CD56 negative. Okay, so this was about the basic concepts. Now we'll start with each type of multiple myeloma, each type of plasma cell disorder. So the first plasma cell disorder which we will discuss today is basically non-IgM monoclonal gammopathy of undetermined distribution, non-IgM. So when I say about non-IgM, so basically monoclonal gammopathy of undetermined significance is of IgM type and non-IgM type. Okay, it is IgM and non-IgM. So non-IgM is basically associated with plasma cells, neoplasm. Okay, and IgM is basically lymphoplasmacytic. ठीक है. So IgM, this is lymphoplasmacytic, like lymphoplasmacytic IgM monoclonal gammopathy, or LPL lymphoplasmacytic lymphomas, or Waldenstrom macroglobulinemia. Okay, it is Waldenstrom macroglobulinemia. ठीक है. So this is about IgM, MGUS and non-IgM. So MGUS can be non-IgM, which is plasma cell neoplasm, and IgM, which is lymphoplasmacytic lymphoid neoplasm. Okay, and also Waldenstrom macroglobulinemia comes under IgM. ठीक है. So that is another important thing which you need to know. Now before we go forward, what you can know is little bit a small thing about. So you can know here about Waldenstrom macroglobulinemia. So what is Waldenstrom macroglobulinemia? Waldenstrom's macroglobulinemia. ठीक है. So basically Waldenstrom macroglobulinemia, it is IgM. Okay, so monoclonal proliferation of IgM type. Okay, so it is lymphoplasmacytoid, LYMP is lymphoplasmacytoid. So it is lymphoplasmacytoid cells. Okay, and this Waldenstrom macroglobulinemia is associated. Now you can be asked a question about this: which of the following is not seen in Waldenstrom macroglobulinemia? So number one, they can say like hyperviscosity. Okay, number A. Number B, you can have CD138 positive, CD19 negative. Okay, number C, MYD88 mutation. Okay, or number D, you can be asked like monoclonal proliferation of M protein, IgM protein. IgM proliferation. So which of the following is not seen? So this is a monoclonal IgM proliferation is seen, MYDD mutation will be seen in Waldenstrom, hyperviscosity will be seen. So this is what not seen: CD138 positivity and CD19 negative. Wellstrom macroglobulinemia is a lymphoplasmacytoid cells. It's a B cell type of cells only. It should be CD19 positive. Okay. So about Wellstrom macroglobulinemia, what you need to know is basically they have MYD88 mutation. So when I say Wellstrom macroglobulinemia, you come on around M. So M is MYD88. So this mutation will separate it from CLL. It will separate it from non-IgM. Okay, and this will differentiate, and it also differentiate from marginal zone lymphoma. It will also differentiate from marginal zone lymphomas. Okay, MYD88 mutation in Wellstrom macroglobulinemia. Okay, Wellstrom macroglobulinemia. M for MYD88, M for IgM. Okay, and this is lymphoplasmacytic lymphomas. Okay, associated with LPL. Okay, that is important thing you need to know. So now coming back to the class, we were talking about non-IgM. So the diagnostic criteria for non-IgM monoclonal gammopathy of undetermined significance is that serum monoclonal protein, it should be less than 30 gram per liter or 3 gram per deciliter. The clonal bone marrow plasma cells should be less than 10%, and there should be no end organ damage. End organ damage, by now we know, when I say end organ damage, I am trying to say about hypercalcemia, renal insufficiency, creatinine, hypercalcemia, calcium obviously greater than 10 in case of our context, or greater than 11, renal insufficiency, creatinine clearance less than 40 or creatinine more than 2, and anemia, that is hemoglobin less than 10, and bone lesion, that is punched out bone lesion, or amyloidosis that can attribute to the plasma cell proliferation disorder. So this end organ damage is not seen. There is bone marrow plasma cell less than 10% and serum plasma protein, monoclonal plasma protein less than 3 gram per deciliter. So this is basic criteria for monoclonal gammopathy of undetermined significance, non-IgM. In case of IgM also similar type of classification you can see, except that you in IgM monoclonopathy, so IgM, MGUS, okay, so you don't see these things. Also there is no hyperviscosity. Okay, there is no hyperviscosity. This also you need to add. So there is no hyperviscosity. This is what you need to know about IgM. Okay, if there is hyperviscosity, that goes towards Wellstrom macroglobulinemia. So there is again MGUS can be light chain MGUS also, where there is no heavy chain. So in this there is abnormal free light chain ratio which is less than 0.26 or greater than 1.6. Okay, increased level of appropriate free light chain, that is increased kappa free light chain in patient with ratio greater than 1.65, and increased kappa free light chain in patient with less 0.626 ratio. So there will be free light chain ratio will be either less than 0.26 or greater than 1.65. There is no heavy chain expression. Okay, there is no heavy chain expression, and there is no end organ damage which is classified by Krebs. Clonal bone marrow plasma cell is less than 10%, and urinary monoclonal protein are less than 500 milligram per 24 hours. So this is classification of light chain monoclonal gammopathy of undetermined significance. So the epidemiology of non-IgM MGUS is basically the 80-85% of the cases they are asymptomatic. Okay, they are asymptomatic. So you are doing test for some other disease, then you find out most of the individuals are greater than 50 years. Okay, they can be also more than 70 years, and 60% of the patients are non-IgM are men. So this is more common in male. Okay, more common in black than white. Main clinical features, they exhibit no symptom of physical finding related to non-IgM. So basically the clinical features are not actually found, and most common type of immunoglobulin which is found is IgG. 60% cases there will be IgG. So this is the most common type found. Okay, this is the most common type of immunoglobulin you find in case of M protein, which you find non-IgM. Okay, so this is the most common type of M protein you find. Okay, so the microscopy, basically you will have plasma cells in bone marrow. You will have plasma cells in bone marrow. Okay, in bone marrow you will have plasma cells, and in bone marrow aspiration also you will show plasma cells like 3% plasma cells. Okay, and immunophenotyping we have already done it will be CD138 positive. Okay, CD138 positive, CD38. So see, plasma, when you talk about plasma cells, no, when you talk about plasma cells, so the polyclonal plasma cells, we have already talked about polyclonal plasma cells are CD38 positive and CD19 positive, CD56 negative, and monoclonal ones are CD19 negative, CD56 positive. Okay, so monoclonal are CD56 positive, CD19 negative in case of plasma cells. Okay, in case of plasma cells, that you need to know. Then you need to know about something about genetics. Okay, genetics of non-MGS. So when you talk about genetics of non-IgM MGUS, okay, so you should remember that this is also a translocation with IgH. Okay, so this IgH, immunoglobulin heavy chain, so there is mostly translocation of immunoglobulin heavy chain. Now this immunoglobulin heavy chain is basically, it is present on chromosome number 14. Okay, 14q32, so basically present on chromosome 14. So there is major genetic in plasma cell neoplasm, basically any type this is non-IgM or in multiple myeloma, the main is translocation IgH. Okay, so IgS translocation that is present in 14. So now when you write MGUS, you can write this way. Okay, so this M basically you can write this way. So this is what this is 11, so there will be 11-14 translocation, there will be 11-14 translocation. This is 4, so there will be 4-14 translocation. Okay, so this you can also think of H, so this is hyperdiploidy, so there will be hyperdiploidy. So these are the major mutations which you see. You will see hyperdiploidy in case of MGUS, you will see 11-14 translocation, 11-14 translocation, and 4-14 translocation. Okay, 4-14 translocation. There can be 14-16 translocation also, but these two are major. Okay, so this is about the genetics. So with this much of information, we'll like to close today's topic, and thank you very much. And I'd like to say you please subscribe our channel, YouTube channel, and you can also contact us on Telegram channel, and you can use my code ANLIV Anil Live, and you can hit the bell icon to get the notification about the classes. Thank you very much. See you in next class. Next class we will complete this topic. We will talk about multiple myeloma, complete detail of multiple myeloma, medical part also, treatment part also. We will talk complete about multiple myeloma. Okay, thank you very much. See you in next class, and hope for a good night.